I express my gratitude to the scientific committee of this meeting for giving the task to moderate this important panel. It's about bladder cancer. So, and to respect the schedule of this part of the workshop, I asked to Professor Carlos Lopes to speak about pathology report in bladder cancer to help the best treatment.
Good morning. Thank you very much to be here and for inviting me. And I want to present my compliments to the table that is constituted by young medical doctors that with them I'm very linked by professional and also scientific reason and essentially by sentimental reason. Well, I will talk about bladder cancer. You know, bladder cancer is one of the most prevalent tumors in all world. There are some variations in histological type, and in developed countries, most of them are urothelial, but in countries where I was born, the squamous cell carcinoma with schistosome hematobium was the prevalent, and it was the theme of my doctoral thesis. It was the bladder cancer associated with schistosomiasis. In Portugal, the data that I could recall, and what was saying that we'll have about 300 tumors in 99, but there are a different distribution, and the interior and, as we call here, the seaside and the mountains have different prevalence and different incidence also, as it occurs with other things. I will talk essentially about urothelial tumors. The urothelium is the tissue that has several patterns in normality, and with usually in urothelium we can find situations in which there is an epidermoid metaplasia, and there we have the squamous cell carcinoma, the glandular metaplasia with adenocarcinoma, but really most of the cases are urothelial, so-called also transitional, yet in some publications, and it is here that we'll concentrate my exposition. They can be non-invasive or invasive, and in the macroscopic pattern, papillary and non-papillary. Essentially, we can find two ways to the neoplastic transformation. One way is in which tumors are superficial growing and with no great invasive capacity. In the other way, they are invasive from the beginning, and usually they lack this papillary pattern, and it is think that the in situ carcinoma, that urothelial in situ carcinoma comes from also this way. Naturally, there are in some cases the possibility that the papillary tumors acquire an invasive carcinoma, but essentially the important is to know that we have two ways of malignization. These two ways of malignization are very studied. We can find also the genes and gene alteration that are found in each of them. And naturally, there is, as I said before, a list of tumors that can be in middle, but really the essential is to stay that there are these two ways to do. To the report, the important is to try to find real collaboration and dialogue, as it was said already today in morning, among all the team that treat these patients and the clinician and pathologists, in order that we can, when we go to see the slides, we can have some clinical data as those that are here mentioned. It is important to be able to interpret. So really, it is very important, and unhappily, it doesn't happen commonly, but really, it is very important to be able to interpret well the lesions. Naturally, it is important also to know if it is the first diagnosis or if we are dealing with material of patients that had before bladder cancer that was already known, and the situation is also different. Naturally, it is also important that we can, in the end, it is important to know the size and age of this patient. Usually, it is important to try to use all the material received to do, to see it at microscope, to have from each paraffin block several sections, and naturally, in this moment, we leave the area of the immunohistochemistry, and the immunohistochemistry, yes, but essentially, I can't expect this paper that was done by the pathologist of the International Surgical Urological Pathologists, that really it is necessary sometimes to do, but in fact, in this moment, to diagnose and essentially to report in either of behavior, immunocytochemistry cannot be so important as it is in other things. The most enemy, it is the fulguration. Really, it is what we see in many biopsies. And here we can see, for example, what it is an area fulgurated and an area in which was the pattern of the tumor. Essentially in small biopsies that are included in only one paraffin block, the fulguration sometimes does not able to report conveniently. To report, we use guidelines. There are many guidelines. Most of them are interbased from the College American of American Pathologists. I think they are the guidelines that we use more, but including in our group, we have in several publications of our group many guidelines to report. So here we have, it happens commonly, we can say how to do, but sometimes we don't do how we say it must be done. To the histological report, it is important to refer if the material that we have is representative or not, what is the type histological of tumor if it is present, the grade, and there are a big discussion if we must report only two division, low and high, or to create intermediate, but the problem is the same. To have 2 grades or to have 3 grades, there are always some cases in which we don't know really where they will be. It is important to refer the microscopic extension of the tumor to say if it is, there are evidence of invasion or not, and it is also important to say always if muscula propria is present or not in biopsy. C'est-à-dire, that's to say that this can also be included in the representative of the material. So the 4 data most important are histological type, grade, extension, and absence or presence of muscula propria. Naturally, these 4 are related with stage. Vascular invasion, namely either lymphatic invasion, if present, it must be reported, and if not present, it must also be reported that it was not observed. Here, the problem is sometimes it's very difficult to be sure if really what we are seeing is the a lymphatic invasion or is a retraction of the tissue. The fat tissue is present normally. We can find it in bladder, so it does not mean that it is a stage 3. For clinician, because the two ways of cancerization are also present in the for the clinicians in way they want to treat, and for them it is important to report always if it is superficial or mostly invasive. And here, the superficial, if the tumor is superficial, the important is to define well what is the histological grade. The tumor invasive, if it is important to try to report the stage. The difficulties that we can find in the interpretation are here. If they are papillary, in papillary tumor, if they are really a carcinoma or it is not yet a carcinoma, it is a tumor with a low malignant potential. If they are invasive or non-invasive, and if they are infiltrative or not infiltrative. Here, there are many discussions if in cases of T1, the separation in T1A or T1B, there are many discussions about this and if the importance to do it or not. If possible, really, I think that this type of things must be discussed in group. In the group must try to say what they really know. The difficulties are here, the presence of muscular mucosa or muscular propria, the lymphatic invasion, the special types of urothelial carcinoma. This is important. We talked today already in kidney, but here also in sarcomatoid tumors like this one, but all of them are high grade. Naturally, there are discrepancies in pathology, and the reports are not commonly with reproducibility. Here we have some numbers of the cases in which who studied the results. We can find that only in 16% of the cases the pathologists agree with the diagnosis of CIS, and only in enough, 60% of cases, the grading and staging are accordant. That's to say that we have discrepancies. This is referred, for example, in this paper, and this discrepancy can have impact in the treatment. To advance, really, the dialogue and communication is important. Consider the possibility to repeat if there are some doubts, new sections, and the immunocytochemistry in some cases. In our practice, we use sometimes the cytokeratin 20, essential to distinguish the low malignant potential and the carcinomas, as we can see the difference. The Ki-cyst7 can help also in the low malignant potential, and the papillary carcinoma low grade and the high grade. Naturally, these slides I choose, that's the slides more convincingly, but in practical type, sometimes it is not so easy as we can see here. Here we have the results that we could have with the P63. Also, the slides I could here show are slides in which it is easy to say that this is muscular propria, this is muscular mucosa, but I choose the best slides. It is not so easy, essentially, when we have fulguration. Definitively, morphology is important, is crucial, but it is not enough, and we must move. Essentially, not only for diagnosis, but also for prognosis and for treatment. And molecular studies are coming, and they are here. Here we can see a lot of the genes that are involved in the urothelial cancerization, and in both of the ways. They are totally different. Here, it is called the way of fibroblastic growth factor. Here, the ways of P53. Naturally, there are mixed moments, but really, it is important to have here. And here we can see, in this moment, the impact of subtypes moleculars in study of some of these cases. We can find a lot of data, and also for bladder, we begin to have this night picture as we note very well in breast, and including the division in luminal and basal types as it occur in breast. We have here this now division, taking account also the luminal, the P53, the basal, and also a small group of Claudine low. Also, as in the breast, it is being possible to try to translate the immunocytochemistry to molecular subtypes. It is not the same. It is not the same. But really, there is some correspondence between some data of immunocytochemistry. You can conclude how it will surely be in molecular type. It is possible. There are all the things are in data, and also we can have, using a small number of immunomarkers, we can compare. Really, most of these studies are being done, they are being validated, but I think that we live already the weather where it happens. We talk already many things about immunotherapy in kidney, also in bladder. It is same point, and also in bladder, PD-L1 and PD-1 must be and can be done, and are being done. The evolution of the immunotherapy is being done, and in this paper, from 1 year before, the future is now. It is what the author said in this case. This slide has already been shown either by Alga, by other colleagues, the importance of to know the PD-L1 to be the treatment. We have seen cases in which we have find positivity, and here we don't find positivity to be PD-L1. So I think I'm talking about new data that can be obtained also from immunocytochemistry. And I will end my talk as aiming that these relationships between the pathology and urologist must be really very well worked, and the pathologist must be aware that he continues to look to the microscopy, to the classic microscopy, but really it is not enough, and he must use immunocytochemistry and essentially molecular data to find a diagnosis, and urologists must exige this data to treat better their patients. Thank you.
Muito bom dia a todos. Íamos colocar então I'm sorry, good morning to everyone. Thank you so much, Professor Carlos Lopes, for your presentation, and I would ask from the audience if there is any question. While people think, I will just make one question for you, if you please, or at least two. One is, when you see areas of low and high grade in a tumor, how you deal with that issue, mainly in papillary, of course. And then if you think that immunohistochemistry is a good surrogate for the molecular subtypes that are being identified by genomic analysis.
Well, the existence of two patterns is common. It is really, and usually in myself, I report the existence of areas of high grade, although I can say most of the tumor is low grade, but there are high grade areas or areas with a special type that must be taken into account. It is what I do. I report both of them, and I don't say only the prevalent pattern. Well, I think that the second question, of course, yes, I think in my, as you know, the problem of molecular pathology and the evolution to the is sometimes, it depends from where we are working. An hospital as yours, I think it is out of question, and either in a first phase in a research attitude, and after in the routine, I think that some of this data, of molecular data, must be reported and must be set. It is really, I'm convinced that it is necessary to be clearly done.
Is there any question from the audience? No?
I have a question. Recently, I read a paper that I think is a very, very important paper. Is the paper of the European Urology of the classification of the different molecular subtypes of bladder cancer. And for me, it's difficult to understand because the classification of molecular subtypes is different of morphological classification because they are basal, papillar, extrumal, and this is not a morphologic classification. And when I read basal, papillar, extrumal, and this is very important for the next step in treatment, and why the classification, the basal and the extrumal and
because when you are classifying a tumor in molecular subtypes, and you are classifying the number of genetic alterations that were found in this tumor. So we take off the DNA tumor, we transform the RNA tumor, and it is what you see is the genetic alteration, the mutation, the gains of DNA. You are not looking to the tumor. We are letting the DNA tumor. Well, and you can use them, and it can be very important. The genetic alterations can be very important in order to add the treatment, because we can link that when this gene and this gene are mutated, the best way to treatment is with this. It is this treatment. So morphology does not go down. But really what happens is that when we have the tumors and when we know which of the tumors have been classified as basal, it is the basal cell, the basal cells that are also, and the luminal, they have the luminal cells. So, but when we see this classification, we try to know which morphological type can be compared. And it is for that although not having the genetic alteration study done, we can say that this tumor with this immunocytochemistry probably is a basal is a luminal, is a stroma rich, is a p53. We can do some comparison, but it is not same. In this moment, we don't have yet genetic arrays to study all cases in the routine. In the breast, you have already some mama print and oncotype. In breast, we have in the market. In bladder, we don't have yet, but we are in way.
Okay, I think there's one more question in the audience, and we'll move on. Thank you.
Yeah.
And this is completely different, because when you are talking about the 80% of urothelial carcinomas, which are just PTA tumors. And this is just for muscle-invasive carcinoma.
What is validated, but there are some data that began to say that for non-invasive it can be, and surely it will be. I'm not sure. The question is, we are in beginning. Yeah. Thank you.
Thank you, Dr. Carlos Lopes. We will move on. Now I'm calling Dr. Maurizio Brausi. He's a well-known urologist. He is the head of the Department of Urology Department from Sant'Agostino Ospedale in Modena. Maurizio, it's a pleasure to have you among us. So you are going to talk us about treatment and how do I treat high-risk superficial bladder cancer? Please.
Thank you, Mr. Chairman. Thank you, first of all, to my good friend Fernando for this kind invitation. It's always a pleasure to be in Lisbon. I like this city very much. And I like also this meeting because, I think there's many medical oncologists here. Can I ask you a question? How many urologists are in this room? Oh, it's not so, that's a lot. My talk would be very, very practical talk and would be about the treatment of high-risk non-muscle invasive bladder cancer, which is one of the most common treatment we do in our everyday practice. First of all, we have to define it. This is the EU guidelines definition of high-risk tumor. Any of the following: T1, high-grade CIS, multiple recurrent and large, more than 3 centimeter, TAG1, G2, low-grade tumors, and in this case, all features must be present. This is what we are talking about today. These 3 entities, TA, CIS, and T1. CIS, I would start with CIS. The definition, everybody knows, flat, high-grade, is a urothelial carcinoma which does not invade the lamina propria. We have 3 clinical entities: primary, pure, no previous tumors; secondary, found after previous papillary bladder cancer; or concurrent, found when associated to exophytic tumor. And we have to remember the vast majority of the cases is in the bladder. However, we can have it also extravesically in prostatic urethra and upper urinary tract. We have to try to find it. This is the molecular basis of CIS. You already had a slide. I will skip this. And the incidence of CIS with white light cystoscopy and TUR, as reported in literature, varies between 5 and 10%. However, if you just search for it with the multiple biopsies in case of suspicious or positive cytology, and you do 7 biopsies, you can have an improvement in the diagnosis from 10 to 17%. And the concomitant form of CIS is more common. This is the diagram URTC has done in order to facilitate urologists. And how can you make the diagnosis? Urine cytology, 90% sensitivity, 95, 98% specificity. This is very important. When you have a positive cytology, you have high-grade disease. Cystoscopy, the differential diagnosis must be done with cystitis, and bladder biopsies, as I said before, at least 7, according to the ORTC. There is a couple of caveats. Can coexist in a normal-looking bladder mucosa, and the denuded urothelium may result in negative biopsies. How can we improve the detection rate of CIS? Because we know that in infiltrative bladder cancer, when we look for CIS, in this patient we have also 60-65% positivity rate. And we can do it with PDD. It's recommended by EU guideline when CIS is highly suspected, and in case of positive cytology and negative cystoscopy, and when high-risk tumor is suspected. And how about treatment? First, standard treatment CIS is BCG maintenance 3 years. All guidelines. I quoted the EU guidelines, however, also the AUA, also the NCCN guidelines are the same. The treatment, my personal attitude is TUR, multiple biopsies, always when suspicious or positive cytology are present, followed by BCG maintenance for 3 years. Just follow the guidelines. How about T1 high grade? First of all, in order to define it, we have to subdivide T1 in 3 types. PT1A, microscopic invasion, PT1B, deep invasion, PT1C, when plexus venosus is invaded. And this is what appears T1. This is the pathology. And this is the final result of a very important URTC trial, which we started in 1995, and says that adequate TUR in this period and block TUR followed by BCG with maintenance 3 years is the best possible treatment of this disease. However, the long-term result after a conservative treatment are these: recurrence rate 56%, 23% of progression, mortality rate 8%. And more recent data, 2017, 25% progression rate, which is not so good. My question is, can we do better? And just saying this, implies the role of early or immediate radical cystectomy in this patient. Of course, it's controversial. Because if I ask here, how many of you do immediate radical cystectomy in a patient with T1 high grade? How many? Raise your hand. 0. So the standard treatment is conservative. However, I would say that, we saw here, is few centers adopt this policy. Why? Because radical cystectomy is a difficult operation. Type of diversion plays a role, of course. The mortality rate varies from 0 to 3% in patients less than 65, but reaches 10% 90-day mortality in the elderly, more than 80s. The complication rate, Clavien 3-4, even in the most experienced centers, approaches 60%, or 50% at least. Many patients have comorbidities and are at risk for surgery, and patients try to avoid this surgery and ask for conservative treatment. These are altogether many reasons for this. I don't put the skill of the surgeon, which is also important. But going through the literature, what I found striking is that despite RTUR, the rate of understaging after radical cystectomy varies from 40 to 64%. So we are not good in doing TUR. And another important factor is that the rate of positive node in T1 high-grade TCC is not 0, varies from 8 to 16%. So when you talk to the patient, you have to tell this data also. And I noticed that in my department, for instance, many of my colleagues do not talk about this. So look at this paper. It's the characteristic and outcome of patients with clinical T1G3 treated with radical cystectomy. This is a result from an international cohort of patients. 1,136 patients with T1 high grade treated with radical cystectomy from 12 centers, Europe, US, and Canada. Medium age, 67, after 4-year follow-up. Rate of upstaging after radical cystectomy, more than T1, 50%. Lymph node metastasis rate, 16%. Downstaging to less than T1G3, 21%. But look at this, 35% of these patients died of metastatic disease, which is, a good number, a high number of patients. So, first question came to my mind is, when we look at the tumor, is it really T1G3? We need, in order to be sure, we need an adequate specimen. Muscle must be present in our resection. And then there is also an inter-infrapathologist variation for stage and grade. Was my previous question to the previous speakers, because this is an issue also. And just muscle present in T1. If you look in the best center possible, Memorial, 60% muscle present. In my center, when I came to Modena, look at this, in 2001 was 51%. After dedicating teaching program, with my residents, came up to 85%. However, if you do M-block TUR, this is very important right now, you reach 94%. So M-block TUR now will become the standard TUR. How about interpathology variation? Look at the grade. It's a lot of variation. And this is from pathological point of view, of course. So we have to cope with our pathologists. But in many centers, there is no big connection between urologists and pathologists. So the conclusion of the interpathology variation is also the EU guidelines 2017. In difficult cases, we have to define this, consider an additional review by an experienced genitourinary pathologist. One of the major questions from pathologists I know that there are not dedicated GU pathologists. However, we know that T1 high grade is an heterogeneous disease, and despite prior reports demonstrating an improved cancer-specific mortality in patients who receive early radical cystectomy, the role of the cystectomy remains controversial. We know this. And mainly, there are no randomized prospective studies comparing early versus delayed radical cystectomy. However, what we have arguments in favor of radical cystectomy. For instance, this study by Denzinger compared cancer-specific survival in 185 patients with T1 high grade, plus at least 2 or 3 characteristics like multiplicity, diameter more than 3 centimeters, CIS. 54 patients received early cystectomy versus the other patient who received delayed, and for recurrence, CIS present, or progression to muscle invasive. And look at the result. 10 years, cancer-specific survival, early radical, 78, delayed, 51%, which is statistically significant. So the conclusion, delaying cystectomy in high-risk patients reduces the 10-year cancer-specific survival in a significant proportion of patients. However, should we treat all the T1 of the bladder with immediate radical cystectomy, or should we select also some patients? Question is, are there some patients to benefit mainly? I like to quote this Donald Skinner statement. Was 97. Look at this, 97. We cannot identify accurately which of these T1 high-grade tumor will progress to muscle-invasive disease and metastasis. Genetic alterations such as P53 mutation may help in the future to make therapeutic decisions. Radical cystectomy will cure a high rate of high-grade T1 TCC with acceptable morbidity and low mortality. In an era of nerve-sparing radical cystectomy and orthotopic neobladder, early radical cystectomy is an alternative that should be discussed with patients before instituting intravesical therapy. This is a good statement, I think, and was done 97. Look at what happened after 10 years. Ayla Skinner, the best treatment for high-grade T1 bladder cancer is cystectomy, again. And then this is another important paper. Use of radical cystectomy as initial therapy for the treatment of high-grade T1CC of the bladder. This is a SEER database analysis. And we know that SEER database analysis has some flaws, we know it. However, gives us a perspective, a feeling what happens. So they collect 8,467 patients, and 397 had radical cystectomy, immediate. Surgical patients were significantly younger and married. Surgical patients had significantly improved overall survival and other causes of death. However, cancer-specific mortality at 1, 2, 3 years was not statistically different. But look at this. Progression was higher in patients treated conservatively. This is an issue also. And then we have also, I like to quote also this one, was at least 30 years after, 20 years after the Donna Skinner's statement. This is a study improving to select criteria for early cystectomy in high-grade T1 is a meta-analysis, 15,000 patients, and they collect the data on recurrence, progression, and cancer-specific survival from 73 studies. The result, 5 years from 56 studies, 15,000 patients. Recurrence rate, 42%. Progression, 21%. Cancer-specific survival, 87%, which is not so different from our Altman data, 85% cancer-specific survival with early immediate radical cystectomy. We have to remember that 20 years ago, very few centers did it. And Richard Altman was one of the most important centers who did it in Europe. And then, in the same paper, they looked for prognostic factor meta-analysis from 33 studies, 9,000 patients. The highest impact factor, risk factor was the depth of invasion, T1BC. This is important. So, we should ask our pathology to stratify our T1. Is T1A, T1B, T1C? Other factors, lymphovascular invasion, CIS, non-use of BCG, tumor size more than 3 centimeters, older age, pathological architecture, micropapillary mainly. How about biomarkers? I mean, I will not go into detail, and then we heard that the genetics alteration and genetic mutation will be the future. However, right now, we have no biomarkers that can be used routinely for selecting high-risk T1 TCC of the bladder. In an era of personalized medicine, we have to use what we have. So we have to use our clinical, pathological, and sometime in some center when they do it, biomolecular also. And so I will go to the TA high grade. What is the treatment? The treatment, standard treatment is TUR plus BCG maintenance 1-3 years. And the great majority of urological center follows these guidelines. There is some debates on maintenance duration, 1 year, 6 months, 6 installation. However, my personal attitude, since I was requested for, is accurate TUR, follow BCG maintenance for 3 years. Multiple recurrent, more than 3 centimeters, TA, G1, G2 low grade. Standard treatment, TUR plus BCG maintenance 1-3 years. And however, my personal attitude is a little bit different from guidelines. I use device-assisted therapy, and mainly I use EMDA, electromotive administration of mitomycin C. So in conclusion, how about the treatment of TA high grade, adequate TUR with BCG maintenance 1-3 year, multiple recurrent large TAG1 low grade TCC, TUR BCG maintenance 1 year, device assisted is a good option. CIS, TUR biopsy followed by BCG maintenance for 3 years. For T1 high grade, early radical cystectomy is indicated. This is what I think. Upstaging more than T1 is observed in about 50% of the cases. This is the reason. Second reason, lymphadenectomy is crucial for removing micrometastatic disease. And clinical, pathological, biomolecular marker, when we can do it, must be considered for patient selection. And in patients with this characteristic, T1BC, TCC, when CIS present, lymphovascular invasion, large tumor diameter, micropapillary variant, multifocality, immediate early radical cystectomy is strongly indicated, I think. And just in conclusion, I think that patients with T1 high grade mainly, early radical cystectomy should be proposed much more frequently and at least discussed as possible option before of any adjuvant therapy you do. And with this is the 10th anniversary of ESU in Rome, which is I'm the chairman of it, and is an invitation. Next ESU meeting will be held in Copenhagen during the EAU, and will be Saturday, 17 March, from 12 to 14:15 at the Congress Center. With this, I thank you very much for your attention. No.
There are some questions from audience.
Yes, quick question. What is unblock TUR versus TUR BT? What do you mean by unblock TUR?
Unblock TUR is a technical procedure when you use you can use it, the Collins, I mean, it's a technical stuff. You can use laser, maybe everybody knows about laser. It's a fiber. You go just in the, I mean, I need a video to show, but you know, just, you go just, you circle the tumors, and then you take also the muscle deep. And so you have one block of tumor, lamina propria, and muscularis mucosa in block. Doing this, you have 94%, if you go to the literature, of muscle present in the specimen. And so the pathologist can make a very precise diagnosis. Because one of the most important, deficiency we have as urologists, that sometimes the base of the tumor is not taken properly, because the TUR determines a cauterization of the muscle sometimes. Personally, I use cold cup biopsy of the base, 3 or 4 fragments, and so I'm very sure that the tissue can be read very easily by the pathologist. But many times, in the majority of the center, they do a deep TUR, but the different from unblock and normal TUR is that one. I mentioned laser, but you can do it when Collins. There is a special loop called Collins. It's just like this, and then you do it, or also with the normal loop.
Very nice talk.
Thanks.
Could you add some clarity to the role of repeat resection in T1 disease to help further stratify?
Yeah. Good question. I give you my personal view, of course. As you probably know, I mean, I'm an author of guidelines, or at least in the Journal of Urology appeared in the global perspective of this one. In my personal everyday practice, I use repeat TUR only in selected cases. First, when there is no muscle in the specimen, of course. When my coworker come to me and say, I'm not sure about the work I've done. Third, every time patient coming from another center. And if you are working in a tertiary center, you must do it. Fourth, in any case you are, I mean, prospectively think about a bladder sparing procedure. And when the pathologist is not sure. Not in every case. For instance, you have one single tumor in the lateral wall, you know, you do a perfect resection, you have muscle in the specimen, there is no other areas in the bladder, I don't do it.
So we need to stop, please. More 2 questions, because it's Pedro Oliveira and
You talked about
quickly.
You talked about understaging, and my question is, do you think there is any potential on MRI as a method to evaluate the decision? Because, you know, MRI previews from prostate has changed the panorama, and my question is that we have about 20% of the cases which are PT1 tumors, potentially, and these are the difficult cases because for many years has been lumped with PTA, which is a completely different tumor. And so my question is that, do you think MRI can
It's
help
an
you?
excellent question. We are studying this. There is a lady in Italy, it's Valeria Panebianco, is a leading lady of MRI, and we are doing a study on MRI, and we are able to differentiate in some cases, we have no enough data to show, but is the new avenue. I think so. Okay?
One question and one comment. What is the proportion of patients, of your patients, that complete the 3 years of BCG? I'm pretty sure that it must be less than 50%.
Take a mic so everybody can hear.
I would like to know what is the proportion of your patients that can complete the 3 years of BCG. That's the first question. And second, I think that indications for RE2R are overweight because in our experience, we don't have 40 to 60% of positive margin in the RE2R of the bladder. So those values are not real life.
Okay, I will answer to the first question. I show you the largest trial in the world, 1,300 patients, randomized in 4 arms, BCG 1 year maintenance, BCG 3 years maintenance, 1/3 dose BCG 1 year, 1/3 dose BCG 3 years. In these trials, at least 55% of patients could conclude the 3 years maintenance treatment. Okay? It's very much dependent of the compliance and of what you tell the patients and how you follow the patients. And one of the most important things is to give to a patient a phone number in order to reach you or your coworker or your nurses anytime he needs. Otherwise, it will stop, especially old patients. Old patients must be, aware of what they have and the importance of doing BCG maintenance, because maintenance is the magic word. You know, if you don't do maintenance, also CIS progression rate is higher. The second question to you is, you are perfectly right. And now I'll answer also my previous question from Professor Dare. We look at our progression and recurrence rate after the selected RE2R, and it's low. It's 4%, 3%, 7%. And look about my center, Palau Center, Fred Wich's Center, which are tertiary center for bladder cancer, I think.
Many thanks. Andiamo. I would like to ask to Dr. Stefan to speak about surgery alone in invasive bladder cancer. Thank you for coming.
Thank you, Dr. De Silva and the committee for having me. This is a real treat and honor to be in Portugal. I grew up in the southeastern portion of the United States. I now live in North Carolina, but I grew up a little north of that in Virginia, and we often talk about Southern hospitality, but I think I'll go back and talk about Portuguese hospitality, and everybody's been so gracious. I will tell you, I'm not sure I'm going to be able to keep up with all the social eating and drinking, but true to my nature, I'm going to go down in a blaze of fire trying. So I'm going to talk to you a little bit about surgery alone in muscle-invasive disease, and hopefully in the first talk, part of the talk, clarify what I mean about that. There's going to be talks later today on adjuvant and neoadjuvant chemotherapy, and then a talk on chemoradiation as a bladder-sparing option. And this kind of sandwiches somewhere in the middle. So I'm going to get started here and just kind of look at the outline. I'm going to talk about neoadjuvant chemotherapy, and not to steal any thunder from Elizabeth's talk to come up, but I think it's hard to talk about this in a silo unless you set the stage a little bit. I'm going to look at the current guidelines. I'm going to suggest to you, or at least to start thinking about, does everyone really benefit from neoadjuvant chemotherapy? I'm going to briefly touch on and delve into the concept of, are there patients that can take surgery alone? And that's just not just cystectomy. Can you TUR alone for muscle-invasive disease? I would have said 20, 25 years ago, I think people would have thought that was crazy. There's data that has been coming out in the 1980s and 90s that have matured to say that might be an option. Partial cystectomy has gained steam again, and I think that again is rolled up in the concept that not everyone who comes in your office wants to have cystectomy, and quality of life and quantity of life reigns supreme for a lot of people. And then get to this concept that if there are patients that don't benefit from chemo, or are there patients that we can further understand may or may not be the ones that we want to stratify within that thinking. So let's look at just this. We know about 60% of bladder cancer is non-muscle invasive, and then you have this 30% that's muscle invasive. And really what I'm going to be talking about is this T2 or T3A disease, the disease that maybe has a lower probability of being micrometastatic. And again, this just further highlights what I'm talking about, a T2A, T2B, and T3A disease, the disease that's into the muscularis propria that may be on the more favorable side of the muscle invasion disease. So what do the guidelines tell us? Well, these are the NCCN guidelines, so this is what is promoted a lot in the United States. And I think if you look down here, tracking from the top, you'll see a couple things. Number one is they only talk about neoadjuvant chemotherapy followed by cystectomy. They give you an option of neoadjuvant therapy and partial cystectomy. They give you an option for chemoradiation as a bladder-sparing protocol. And then they have this non-cystectomy candidates, which is really a hodgepodge of either A, I refuse to have treatment, or B, I'm just too infirm, or the perception that I'm too infirm to have a cystectomy. And they talk about chemoradiotherapy, TUR alone, and the concept of TUR and intravesical therapy. What about the ESMO guidelines? They give you a little dash line to radical cystectomy of lymphadenectomy, suggesting that is an option, but they really favor the primary line of neoadjuvant chemotherapy followed by cystectomy. And then if you flip to the EU, it's a similar story. They look at neoadjuvant chemotherapy as a primary outcome, and then also the concept of chemoradiation. So what are some of the issues? Inaccuracy in staging. This goes both ways. There's an overstaging. We certainly know that. We think some folks are T2 and they're really only T1. And then there's an understaging. We think some folks are T1 or T2 and they really have a higher staging. And this is highlighted by this study right here. This is Rob Svitek. This was done on about 3,300 patients. And if you scroll over to the pathologic staging and you look at their corresponding clinical staging, you will see to the right that a couple things. Your chance for upstaging in T2 is about 50%. Your chance of downstaging is about 20%, and only 30% were actually concordant. And then with the T3 disease, the chance for upstaging went about 20%, and the chance for downstaging was about 20%. So we know this is an issue. The combination of imaging, of physical examination is not perfect. So what about neoadjuvant chemotherapy and bladder cancer? I'll just scroll down to the bottom and then highlight a few things. The meta-analysis, which I know we'll probably hear more today, showed about a 5% improvement in overall survival. That was a hazard ratio of about 0.86. It was driven by really 3 trials. The first one was really started by the MRC and the EORTC, and that came out first. And about at the same time, the Nordic trial, the Swedish trial came out. And then really what has driven our knowledge of that in the United States is the intergroup trial, or the SWOG trial, that took 11 years to accrue. And basically, it gave us all improvement in overall survival. I will make one comment. The GU1 trial, which only came out in abstract form, actually was randomized. There's not been any more data that has come out of that. It actually did not show an improvement. But this is really what has driven our knowledge. So why not neoadjuvant chemo? Well, first of all, it hasn't been completely adopted. These trends are consistent in the United States as well as in Europe. We have seen an increased adoption in the United States, and Europe has seen an increased adoption as well. But there is some concerns, and I think they're valid. The first is the toxicity. About 30% have grade 3 or grade 4 toxicities. My father died of bladder cancer. He took neoadjuvant chemotherapy. He had terrible neuropathy. I think if you had asked you again, he would not have taken that. And only about 50 to 60% of the patients actually meet this criteria. They have good hearing, they don't have neuropathy, they have good renal function. So that does create some challenges. It's very hard for us to predict who may benefit. I know there's future discussion and future looks into molecular profiling, but in today's world, in 2018, we tend to give it to everyone with an uncertainty. There's inherent challenges with appropriate clinical staging, which we discussed, and there's fundamentally a risk of overtreatment. I think we would all have common ground on that. So again, a couple other highlights. This is from the intergroup trial. This is Bart Grossman's trial. He was retired now, but worked at MD Anderson. So what I'm always highlighted is, yes, there was a benefit, but that magnitude of benefit was greater in the higher stage population. About a 31-month overall improvement in survival, but when you look at the T3, the subgroup, which was a pre-specified analysis, the benefit was more favorable in the T3, T4 group, and that was 40 versus 30 months. And what about the quality of surgery? So that the trials, and that trial specifically was a systemic therapy look. It was not an quality of surgery, but when you look back at the surgery itself, who did the surgery, I think there's some interesting findings that pique my interest. Number one, 50% of the surgeries were performed at academic centers, 50% were not. Only 13% of surgeons performed more than 5 cystectomies a year. I think we would have common ground in this room that it is very hard to get good at a procedure performing it less than 5 times a year. The predictors of survival when controlling for neoadjuvant chemotherapy were also fundamentally surrounded by the quality of the surgery. Did you have negative margins or not? We know that is a bad sign if you have a positive margin following cystectomy. And did you take 10 or more lymph nodes? That started this trend. Another SEER Medicare data set came out later, and this is what has permeated, at least in the United States, about defining the quality of surgery by the fact that whether you have 10 or more lymph nodes. Just a couple quick additional comments on this. Even if you had a good lymphadenectomy or not, that certainly affected you within these groups. If you were N0 and you got more than 10 lymph nodes, you did better than being N0 and having a little or no lymph node dissection, and the same held true in the N1 disease. I will tell you, if you had a limited or no lymph node dissection, your chance, 26% of those patients had positive margins, and that is fundamentally a death sentence in bladder cancer. So looking at the Nordic trial, really the same story. The benefit, again, in the subgroup was greater in the T3, T4 population. Those are the curves. So what is generally accepted rates of cure in pathologic T2? And that's the problem. I said that with some emphasis because I meant it. We're looking at clinical stage often when we look at outcomes following neoadjuvant chemotherapy. And when we look at pathologic outcomes, these are people with true T2, and we know that there's some movement amongst that from the clinical position. So what is this? This is John Stein's study on the left that came out a good while ago and showed really good outcomes, both in recurrence-free and overall survival for T2, and you can even track a little lower and see T3A. And then the same thing with Dr. Haltman's study showing very good outcomes with primary treatment of pathologic T2A and T3A following cystectomy, well-performed cystectomy only. So can we better stratify? And what about risk adjusting? So I think it's interesting. MD Anderson, who ran the intergroup trial, fundamentally now risk adjust. They do not give chemotherapy to everyone. I'm not saying that's wrong or right. I will tell you at our institution, we're very aggressive in giving neoadjuvant chemotherapy to everyone, to offering it to everyone. But I think there is some interest, and I know this has been discussed and permeated across Europe as well. So can we clinically decide who should get neoadjuvant chemotherapy or not, and then direct that treatment based on these findings? So who would be higher risk? Well, you would want absence of LVI. That predicts a higher chance of micrometastatic disease. You would want absence of hydronephrosis, which predicts a higher or more deeply invasive disease. We know that those patients don't do as well. You would want to examine the patient during TUR, because if you can palpate the disease, that does make you T3B. And then you would want to exclude patients with local invasion. And the micropapillary or small cell component. So I think those are relatively standard things that we would say would upstage you or make you more concerning. If you look at these factors, absence of all of them, 10% or less lymph node involvement, if you're low risk, and 30 to 40% if you're high risk, And then this is how you stratify the incidence of mortality. Now, these aren't perfect. However, if you go from low risk to low risk upstage, screen left, you don't have a ton of movement. You don't move all the way down to the high risk category. And then the same thing if you go from low risk where you thought you were low risk clinically, and then you upstage at the time of pathology. So I think there is some validity, there's some merit into thinking through this with patients and understanding there may be some nuances outside of molecular profiling that we may better stratify patients for chemotherapy or not, or give them straight to cystectomy. So this is the protocol that is used and has been permeated to some degree in the United States and in Europe. So you resect the tumor, low risk, goes to radical cystectomy. Any of the other findings go on to neoadjuvant chemotherapy followed by radical cystectomy. So what about the role of repeat TUR to stratify and treat? Harry Hirsch started this data in basically in the late 70s, and this went for about 10 years. And so basically this was about 450 patients that showed up to him. He offered all of them repeat TUR. And then basically the 99 plus 52 patients you see on screen left either had T0 disease or T1, and he offered them either surveillance or radical cystectomy. If you screen right, all the patients that were T0 at the time of repeat resection for initial diagnosis of T2 disease, perception of clinically, had an excellent outcome if you were T0 at the time of repeat TUR in comparison to cystectomy. I will tell you, 18% of the patients that were T0 at the time of repeat TUR died versus 42% who were T1, suggesting that what you really want if you're going to consider this is a repeat resection that macroscopically removes all tumor, that adequately biopsies the muscularis propria, and then is T0. Also added in certainly the lack of multifocality. So what about radical TUR? So this is a Spanish trial that looked at it a little bit differently, but same concept. They did not repeat the TUR. They basically did aggressive resections the first time, macroscopically removed all tumor, then took biopsies into the muscularis propria. This publication is on the heels of their first trial, which they got very smart and said, if we remove sessile tumors, so broad-based tumors, and we remove tumors that are 3 centimeters, we think we've already put ourselves in a better bucket. The chance that you became T2 with a negative TURBT initially and negative biopsies, the chance that you are really T2 in the first year was less than 6% doing that. I'll show you this up here. The recurrence and progression was identical, but your recurrence with non-muscle invasive disease did not predict your outcome of survival, meaning, and if you read the full paper, most of those patients were salvaged with intravesical chemotherapy or intravesical BCG. And similar to Harry Hirsch's study, I think this starts to suggest that there may be parallel tracks or concurrent invasive and non-muscle invasive disease that could be treated differently. And then if you look at the cancer-specific survival, this follows through with Dr. Hirsch's study, and the local progression and bladder-free preserved rate is very, very good. This was a subgroup analysis that was intended, and it just shows, I would think you would be crazy at 28 years old to do this, but it did not matter in terms of overall survival if you were young or old. So who can do radical TUR? We talked about this, so 2 studies, no high-risk features, hydronephrosis, LVI, deep resection. I think I always re-resect, but then again, I sit in a space as a urologic oncologist where most of my patients come from other urologists. And I like the idea of repeat resection and then to try to improve the quality of the resection of the pathologist to grabbing biopsies deep, excluding some logical patients, multifocal, and people with large tumors that are broad base. I think we would all have common ground that makes logical sense. So what about partial cystectomy? And I'm going to make just a few quick comments. We used to think partial cystectomy was not a good idea, and then we went through a metamorphosis where we think it might be a good idea. I know there's a lot of data coming out or starting to come out about chemotherapy used in conjunction with partial cystectomy. I'm talking right here about only partial cystectomy. If you looked at this matched cohort study that came out a couple years ago, it essentially looked at the metastasis-free survival, cancer-specific, and overall survival in selected patients was very good. Who were those patients? Solitary tumors, amenable to the surgery, no concurrent carcinoma in situ, and certainly where you don't have the perception that you'd have to reimplant the ureters. So 94 patients in this match cohort, they had a 38% recurrence rate. 17 or half of those recurrences were non-muscle invasive. They were all salvaged with intravesical chemotherapy or BCG. One caution is the fact that if you do recur with invasive disease, almost all of those cystectomies were T3. So I suggest to people, if you do a partial cystectomy and you recur and they're amenable to chemotherapy, you should come back and probably give them neoadjuvant chemotherapy before consolidating them with cystectomy. Your risk for dying on the recurrence of muscle invasive was very high. So this is just a little bit of a follow-up. This came out around a little bit before, but it's your Medicare data set, and all I'll mention is this is really the same thing in partial cystectomy. Appropriately selected patients probably do very well with partial cystectomy alone and pelvic lymph node dissection. So a couple comments on partial cystectomy and radical TURs treatments. Outcome is probably determined by the extent of disease and not the extent of the surgery. Our clinical experience suggests that partial cystectomy and radical TURBT are viable options for some patients. I think that is a fair statement. Not everyone benefits from upfront chemotherapy. I think we all know that and would again have common ground on that. A well-performed, good quality cystectomy done in the right hands alone for T2 disease and probably T3A leads to excellent cancer-specific survival. Radical TURBT alone is an option that can be considered. Careful selection, repeat TUR, biopsies of the normal muscularis propria and fat if it's present during the resection, and exclude large multifocal sessile tumors. Partial cystectomy, I think, is an option for select patients. Obviously, these are few select patients, but it's something to be thought of. All decisions should include personal characteristics and desires. I think this is always a multidisciplinary discussion. There's a lot of smart radiation oncologists, there's a lot of smart medical oncologists, and there's a lot of smart urologists, and 3 heads are better than 1. And this is something that, these last 2 points are something I've become very sensitive living in the bladder cancer world for the last 8 years. Not everybody walks in your door wants to have their bladder out. Not everyone's desire is to live as long as possible. A lot of times that's our desire, but there's a lot of quality of life issues with the treatments we do, and we have to be very, very sensitive to that and understand that there are personal characteristics and treatment options to hopefully match those up with patient needs. Thank you.
Dr. Ricks, thank you so much for your excellent presentation. Before moving to the audience for one quick question, I would like a comment from you, which is this. I'm a pathologist, so this is my conflict of interest statement. And I became very confused with the last 2 presentations, so yours and Professor Browsey, because in a seemingly not very extensive tumor, we were defending a quite aggressive treatment, and now we moved for an aggressive tumor and a more conservative treatment. So could you enlighten me, so where we stand?
I wish you could enlighten me. Listen, I think what's not lost on me in all of this data and the excellent talk we had before is the heterogeneity of how we define these diseases and the heterogeneity within the disease itself. And what I'm not advocating that everybody who comes in with muscle invasives should go along this paradigm. But I do think there are patients within all this, whether you're T1 and you're a lower risk T1, and I think he was articulating this very well, or a higher risk T1, there is a lower risk T2, and there's probably a higher risk T2. And yes, I think molecular profiling is going to get there, but I think we're also, it's complicated by the quality of the surgical resection, things that we can control in 2018, and we have a broad breadth of that. How it's done across different centers is somewhat different, but just in sheer volume. I mean, if you do 200 of these a year, I think your outcomes in terms of risk are going to be very different in how you look at that. It's a good question. Yes, come.
Small comment. I mean, the magic word is selection. Okay? It's stratification, you know. I mean, I enjoyed the talk. However, if you take the three-modality treatment, because right now is coming and coming and coming with a lot of trial. There are randomized trials going on, or at least prospected. And the new era is to try to preserve the bladder as much as we can with deep TUR, chemo, and radiotherapy. However, if you look at the paper, there is a strict selection of patients. T2, no CIS. I mean, this is no old people because they cannot get chemo. So the selection criteria is the most important one.
Yeah, well said.
Thank you so much. We shall move forward. Thank you so much, Dr. Riggs. And now, and after her excellent presentation on immunotherapy in renal cell carcinoma, I would like to ask Dr. Heath to the stand to prefer her talk about what about neoadjuvant chemotherapy in invasive bladder cancer. Thank you so much, Dr. Heath.
Thank you so much. So this is a hard topic only because this is the first time where we know that there are level 1 evidence right here that says, in this sort of really critical SWOG study, that if you give neoadjuvant therapy, people live longer. Now, this is the only setting where you have level 1 evidence that we try for whole conversations to explain why we should not implement it and also verify why we don't implement it. So whether you see this or not, what the problem is with this set of data is it doesn't pass the gut check. All for the reasons that Stephen just went over, which is in a lot of ways what you and I experience with our patients. So in general, what we didn't talk about is, again, in the selection, it's who do you want? If you knew who that person was, you would give it, because that's really sort of the critical piece. So who is that? Well, that's the guy that's going to get the pathological complete response. That's the guy you want. That's the guy you say to yourself, boy, if I knew he was going to really respond or she was going to respond, it would be worth it, because that's where that person would live on the curve. So we try to play a little bit of, the fortune teller game, because when you're explaining this to patients and you give a litany of all the things that you could do for chemotherapy toxicities and this and that and the other, what you don't know is, where is that person going to fall on this curve? And today in 2018, we still struggle with that question. So many years ago, I was on an ASCO panel, and I had the pleasure of being the person giving the kidney cancer update. And Chris Sweeney was my counterpart, and he was grumbling. He was grumbling the whole time up there. And he's like, how did you get kidney cancer update and all this wonderful sort of TKI immunotherapy? And I got bladder cancer. And my topic is why we should give chemotherapy. It's on one index card. That's all I have. And here we are in 2018, in some sense, having the same discussion, because we still can't figure out who that person is. So it becomes a really difficult topic, but we're getting there. We're making some progress. So you're going to say, well, where is that? Well, here, that guy that has a pathological complete response, 85% of these folks are alive in 5 years. You could justify that. You're right. Is it concerning? You might live with hearing loss and neuropathy. Of course it is. That person is cured, but at a cost. But if you could say for sure that that person would be alive, and that is a meaningful outcome, then at least you would be on the right track. So, as what was seen before, the meta-analyses, I always distill it to really one thing. 13% relative reduction, here's your improvement. Now, I got to tell you, how do you explain that to patients? Oh, by the way, your improvement in your 5-year survival is 45% to 50%. They don't really have an understanding of what that means. It just means that, in general, we're going to lump all of you together in these 10 randomized trials, and thumbs up, you're going to get some toxic stuff. And then, what else do we do in oncology? We like to substitute. So all of that information was with MVAC chemotherapy. But the majority of us, and I don't know for the medical oncologists in the room, we tend to also give gemcitabine cisplatin. So then you say, well, how'd you make that decision? Because it seems to me like the majority of these meta-analyses are MVAC. Well, right, but looky here. Here's a New England Journal article that a JCO article that says, oh, you know what? If you give MVAC or GC, it doesn't really matter because your overall survival will be the same. You have a better side effect profile, so perhaps you should consider gemcitabine cisplatin. And I get that pushback because there again, Dr. Pontus will grumble in our MDT leader, our discussion, and says, you're making my patient too sick. I will have a problem by the time he or she comes for surgery. So we say, look, we'll substitute that out. Now, do I have real data to show that that's a good idea other than in oncology we like to substitute? Not so much, but we do it anyways in actual practice. But there will be a follow-up trial here by the French that actually is looking at that question prospectively. I'm always overwhelmed when I think about that. Here we're in 2018, and here it is, the randomized prospective trial. So it's critical that this outcome will actually be validated, but in real practice, it's probably happening right now. And then, of course, more retrospective data to show that it's equivalent. So that's all well and good, but where are we in 2018? So those of you may be familiar with the prospective study that tries to incorporate this question of, are there molecular markers that can predict who should be that person to get treatment? So this is a trial run by Tom Flagg, and it's a SWOG oncology trial, which finally closed, which when it began many years ago in 2013, we weren't sure if it was actually going to accrue for all of the reasons that you've heard about earlier in our talks. But here it is. This actually is a prospective biomarker-driven discovery. So where are you? Here's your TRBT. There's lots of stuff being collected. Now, when this was proposed in SWOG, we didn't really know, so they said, we're going to do gene expression. We're going to do some sequencing. We'll check something to do with RNA, probably the microRNA, but who knows? Now our RNA knowledge has exploded, and we'll just do a bunch of SNPs too. But this is not arbitrary because there's been a lot of studies leading up to what a person should check. And then the person gets randomized. Here's your GemCis versus MVAC. And then you do a cystectomy, and our pathologist will go and dissect the whole thing and figure it out. And then we do more studies, and we'll figure out at the end of this what will happen. This won't really have a readout for another year or two, but to me, as an investigator thinking about that, that's pretty darn exciting. So that's actually complete, so keep your eyes open for emerging data with this trial. But then there are others, and we saw earlier really critical papers. So if you're gonna read anything in this year in terms of your knowledge building for molecular markers, I suggest that you follow these four. You have the critical Van Allen, Eli Van Allen paper. You got Betsy Plymax, you've got Dr. Liu and Teo, and basically they're all looking at mutations in the DNA damage and response gene family. And that's a recurrent story. We'll hear about that in prostate cancer and other cancers, but for bladder cancer, it's really changed the landscape. So here is an actual prospective trial that's being led by Betsy and the Fox Chase team with other institutions, and this is what they're doing. Here's your TURBT. They are sequencing and looking at specific mutations in ATM, Fanconi's, RB1, ERCC2, with a variety of other genes, but really trying to figure out, after you give 3 cycles of MVAC, this is what they're planning on doing. Again, no residual tumor to higher than that, what the plan is. So to me, this is a really exciting prospective study that actually looks at that, but that again will have a readout in a little while, right? It's not for today here in 2018. And I bring up this because we've had a really great discussion and terrific papers. I mean, I look at this and I go, wow, that's 4 major subgroups that are molecularly subtyped, and you have your luminal and you have your basal, but in actual practice, and I challenge our pathologists to help us, we don't know what to do with this. In fact, when we actually review bladder pathology, we don't even talk about it. So I'd like folks to raise their hand if in your MDT group, do you mention or do you ask your pathologist for such a breakdown? Raise your hand. Okay, I can tell you from up here, no one's raised their hand. And I think this is perhaps a missed opportunity because the merging of this with all the molecular data hasn't been smooth. So there's a little bit of a diverging tract in how we're thinking about this, and we're not leveraging our pathology colleagues, and they're not thinking, it's sort of like just morphing into this thing that's developing separately. And I encourage, since many of us are in the room, could make this change, I think we had to pay attention. Look at basal tumors are much more sensitive to chemotherapy. How are we not using that data now in 2018? The immunotherapy story, I know we'll hear about that, I think tomorrow from Dr. Sternberg. This is now even more complicated because immunotherapy has a story in bladder cancer all the way from the BCG days. So patients are much, much more actually inclined to understand that because they know that it's been part of the history of treatment. So I've had many patients who say, well, I'm on immunotherapy, my doctor's giving me BCG. Well, he is absolutely correct. But there are now many trials in the neoadjuvant space, and I encourage you to also keep your eye out on that, where you have combinations, singles, you have, again, also chemo plus. There's the clinicaltrials.gov number. They will be emerging probably in 2018, 2019, so keep your eye on those studies, because this will be actually quite interesting with the chemotherapy plus the immunotherapy. So hopefully that's a quick snippet as to what's really happening in the neoadjuvant space. I think that we have to think about who that person will be who will get that path complete response and utilize some of the emerging genomic and pathologic subtypes to figure out who really should benefit. Thank you. Questions?
Dr. Hicks, thank you so much for your talk. Is there any question from the audience? Yes, please, Professor Browsey.
One of the major problems we face in everyday practice is the age of our patients.
Yeah.
We, at least in our institution, we have at least 40% of patients more than 75 who have muscle invasive disease. And we adopt, of course, neoadjuvant. So my question to you is, how many of these patients can really tolerate or get therapy? This is the main question to us, and because I see in MDT that this cannot do it, we can, our medical oncologists are a little bit, afraid of toxicity. What do you suggest to us?
Yeah, so I always say I'm not an ageist because there are folks who come in at 80 who are quite robust, so it has to pass the same eyeball test. So I always say, if you guys will operate on this person and have that person endure 6 to 8 hours on the table, I am happy to give chemotherapy. So I think it has to be a joint decision, not so much just a 75 below or over. It really becomes sort of that person's biological age. What I also worry about isn't the short-term neoadjuvant, it's that if you do surgery, how will they care for their ostomy, and all of that as well, which becomes slightly harder sometimes post-neoadjuvant for them to heal up. So a lot of those questions, and I'm sure Dr. Raghavan will talk about that from an adjuvant perspective, because that will also impact whether somebody could get that. But up front, I have given chemotherapy to 80-year-olds.
Well, I'm sorry. For the sake of time, and I know the talk is very interesting, but we really should move on. I invite you all to have this talk afterwards, okay? You can really go on. And this, for the sake of time, we are really to move on. So thank you so much, Dr. Heath, for your excellent talk. And we will move on. And now are really exciting times for us. I'm a radiation oncologist. There are not many radiation oncologists here in the room, but you'll see that we are really changing the shape of how to approach this new entity. Well, and for that we have Anthony Zitman. He comes from Mass General. He's a radiation oncologist, and he's one of the radiation oncologists who put out last year a very nice paper stating what's the real stand for radiation in the 3-modality treatment options. So, Anthony, you are very welcome. We like a lot to have you among us, so please let us know what your thoughts about radiation oncology in this setting.
Thanks so much. My job today is not to threaten urologists. I'm not here to take your jobs away, to take the cystectomy away from you. I'm here just to talk a little bit about a reasonable alternative to cystectomy and how we can work together. So, organ conservation is just part of the language of contemporary oncology. whether we're talking about laryngeal cancer, breast cancer, anal cancer, sarcomas of the limbs, everyone wants to spare their organs of communication, organ of defecation, the organ of ambulation, and all these approaches use combinations that they have in common. Some surgery is always involved, some degree of limited surgery. Radiation is involved, but not the kind of radical high doses, something a little less. And systemic therapy, usually to sensitize the radiation. So the alternatives to cystectomy certainly include aggressive TURBT. And you've heard already data about small T2 tumors, the 3 centimeters or less. Many of those can be cured by TURBT alone, but they are the minority of patients with muscle-invasive bladder cancer. Radiation therapy alone has a pedigree in T2 through T4 disease. It's not bad. It's not great, but it's not bad. It's better than the TUR alone, probably, for the more advanced disease. But alone, it isn't enough. It's certainly enhanced by the addition of sensitizing chemotherapy. And if you look at the methods for bladder preservation, they really have improved over the last couple of decades. We've learnt how to combine chemo with radiation, which drugs go best with radiation. We've really learnt the importance of an upfront debulking TURBT, even for T3 and T4 disease. And probably most important of all is we've improved our patient selection. Obviously, there are better forms of radiation delivery, but I don't want to talk to this audience about that. That's a sort of technical detail. But it is important because patients doing trimodality therapy, a significant proportion of them will need a cystectomy down the line. So we have to leave as much bowel as possible untouched so that you can use it for diversions in the future should it be needed. So we've learned about combining chemo with radiation. I'll just cite one paper. This was Nick James's paper in the New England Journal of Medicine. Radiation with a TURBT versus combined modality therapy. That's the addition of sensitizing mitomycin C and 5-FU. This is not very tough chemo. It is so much less than MVAC or GemCis, certainly at the doses that they used. First of all, you can notice that radiation with a TURBT for T2 and T3 tumors, clinical T2 and T3, the local control rates really weren't bad, but they were improved by 15 to 20% by the addition of chemo. The need for a maximal TURBT, and this really means, down to fat if necessary, is very important. We ask you to do 90% of the work. We ask you to do 99% of the work, if you possibly can. That's what happens in breast cancer. That's what happens in limb sarcomas. There is debulking surgery initially. And our data would suggest that simply by doing an aggressive TURBT, you increase the local control rates within the bladder by about 20% over chemoradiation alone. Over chemoradiation if the TURBT is not complete. Now, some of this, of course, links with the original size of the tumor. The smaller the tumor, the more likely the TURBT is to be complete. But this actually is an independent variable in multivariate analyses. And these are the various improved methods for bladder preserving better selection and better radiation delivery. So I've said that patient selection is the key. We want that visibly complete TURBT. In our ideal world, all the tumors would be tiny. But at the Mass General, at least 50% of our patients have T3 cancers. These are not tiny cancers. But our cure rates with T4 are substantially lower. Ideally, we would have no tumor-associated hydronephrosis. But we will treat patients with hydronephrosis if cystectomy is not a great alternative. These are our results from over 470 patients. We have long medium follow-up, something like 8 or 9 years. Disease-specific survival is really very good, T2 through T4A, mostly T3 patients. And when you compare the younger with the older, there's nothing biologically worse about the cancers that are present in older patients. Older patients are less able to tolerate cystectomies, but they're usually pretty capable of getting through chemoradiation, at least the way we now do it. And actually, that's an important issue. About 40% of our patients are over 75. If you look at patients across the United States, this is an NCDB study, you'll see that by the time you get to 70, the majority of patients are not having a cystectomy, but they're not having chemoradiation either. They're being managed in a palliative sense, usually with repeated TURs. So we actually think there's a big unmet need in elderly patients. Without reducing the number of cystectomies by even one, we could plug in chemoradiation to help soak up some of these older patients. If you look at overall survival, and of course that's the most important issue when we first confront patients, and you compare clinically staged patients from a big cystectomy series or big radiation series, overall survival does not seem to be compromised by at least initiating a chemoradiation approach. Why do I think survival is not compromised? Because we bake salvage cystectomy into our protocol. If there is any hint that the patient is not going to be cured by the chemoradiation, we do a check midway through the chemoradiation, we do regular follow-up, then that patient will go to a salvage cystectomy. When we look at the quality of life of our patients, and you've heard this already, patients don't want a cystectomy. They don't even necessarily put survival number one on their priority list. Quality of life is usually number one. So there have been a number of studies. These are 220 of our patients with T2 through T4 disease who we treated on protocols over an extended period of time. We invited them back to do questionnaire studies and formal urodynamic studies. We were very pleased to see that the vast majority actually had well-functioning bladders after their TUR, their radiation. 78% had normal capacities and flow parameters. Very few had residual urinary symptoms. Interestingly, the biggest knock on chemoradiation were bowel symptoms. A lot of our patients had mild to moderate bowel control issues. So that's something we've worked to improve with modern radiation techniques. And erectile function was reasonably well preserved. More recently, we've actually done comparative studies at the Mass General, chemoradiation versus radical cystectomy. And I'm not going to go into this data in detail, but the bottom line is that combined modality therapy was associated with actually a slightly higher general health-related quality of life. And actually, to my surprise, bowel function was better than radical cystectomy, because of course, radical cystectomy has some consequences for bowel function. And sexual function was better in chemoradiation patients. Also, the chemoradiation patients had a better perception about their overall experience. They felt more involved in their care. And they were less concerned about, obviously, body image changes, because usually they did not have an ostomy. Now, when we meet a patient in our combined modality clinic with an invasive bladder cancer, and we are contemplating chemoradiation, we have to know that that patient understands the importance of lifelong surveillance. There's the disease we know about now, and there's the disease that may either recur or may develop de novo in the future. So if a patient is not going to be compliant with follow-up, we actually feel that cystectomy is the best initial approach. Again, these are our results, which we've recently updated and published in European Urology. Of those patients who have a clinical complete response to chemoradiation, and it's actually in selected patients, it's about 85% now. If you follow them long enough, about 30% will have a non-invasive recurrence at some stage by 10 years, and 17% will have an invasive recurrence. So vigilance is essential. So the urologist is not sidelined by chemoradiation. The urologist is absolutely central to chemoradiation. You're involved in the initial TUR, in the response assessment, and then surveillance for life. And then, of course, the salvage cystectomy, if it becomes necessary. And of our patients requiring cystectomies, if you compare those who had them immediately with those who had them later, we do seem to salvage a lot of patients with cystectomy, so long as we do it in time. That is because I think we do it in time. And what are the consequences for a salvage cystectomy of having had chemoradiation in advance? Well, we've compared our 90-day morbidity using a Clavian scale with Memorial Sloan Kettering and Harry Herr's wife, Michelle Donat. She published on primary cystectomy. And we've compared the 90-day morbidity. And they're comparable. There is a little bit more lower grade morbidity if a patient has had chemoradiation first than if they have a de novo cystectomy, but it's not that much. And the management of late non-muscle invasive bladder cancer recurrence, well, largely these are managed as you would manage any superficial cancer, usually with resection and BCG. And we've actually found the BCG is tolerable, despite patients having had a reasonable dose of radiation in the past. So, in our opinion, combined modality therapy for muscle-invasive bladder cancer patients should be used selectively. I mean, we just do much better with T2 and T3 disease than we do with T4. But it's not like a cystectomy is so marvelous with T4 disease either. None of us want to treat T4 disease. We'd rather not see it. Chemoradiation is now approved on all the latest NCCN, EAU, and AUA guidelines. And it's improved because it really does seem to be pretty well tolerated, even in the elderly, and remember that great unmet need. Survival from cancer actually is pretty stable from about 5 to 15 years. The retained bladder functions reasonably well, and really very important because patients want it. And not only do they want it, they seek it. 50% of our referrals come from Dr. Internet. And it's often not presented very well to the patient, even to the elderly and unfit. So the AUA guidelines say that even if you don't offer it, you've got to at least, even if you don't do it at your institution, you should at least present it as an option. And if the patient wants it, you may have to refer them elsewhere. So all the major urologic and major oncologic societies support it. As I've said, it's approved within all these latest sets of guidelines, and patients want it. And patients are on the internet all the time. I don't know whether they are in Portugal, but I'm pretty sure they are. I can assure you they are in the United States. And the discussion really starts in the multidisciplinary clinic. It used to be that urologists would remove the bladder, then send the patient to the multidisciplinary clinic to decide what to do next. Now what we do is think first, and perhaps not remove the bladder at all. Thank you.
Thank you, Anthony. Great talk. I don't know if there are any questions in the audience. One question, yeah. Yes.
It's coming.
It's coming. Just a second.
I like you talk very much for many reasons. I have learned a lot in this conference today. Among my pleasant experience has been young people such as Steve Riggs, who at his young age already realized that nobody would like a cystectomy. Let's face it. And I did cystectomy by the tons in the past. The second is that I have followed, and I saw that you are Shipley, a professor of urology. I knew Bill Shipley very well. From the very beginnings of the National Bladder Cancer Project, of trying radiation therapy together with cisplatinum alone in patients that were not candidates for surgery. I was part of that study. We entered the largest number of patients from Roswell Park that I was the chief then. And I follow the initial work from the Mass General of using MCV, that's in fact without adriamycin, together with radiation and restaging the patient, and I think it's a very valid way to present patients. As one ages, I no longer propose cystectomy for everybody, and I always discuss bladder salvage protocol, in which I think what you presented is a very viable alternative. The only thing that I discuss with the patient is that if they need a cystectomy, usually they are no longer candidates for continental urinary diversion. Otherwise, it's a very valid approach, since I agree, nobody would like to have a cystectomy, at least I wouldn't.
Yeah, you are absolutely right. And we do present this to patients at the very beginning. If you have chemoradiation and you're one of the 25% who need a cystectomy, a neobladder is probably not going to happen.
One more question, and
good
we have
talk.
to move on.
However, I'd like to be a little bit provocative, of course. Everything fine, but how many patients does fit with the trimodality treatment, talking about chemo again? You know, and in the light of the new paper produced by Stephen Williams from Sears database, they had 687 patients, trimodality versus 687 radical cystectomy. The result, much in favor of radical cystectomy, costs enormously higher in trimodality treatment. This is another issue. And this is most important when, in the long run, after 6 months, 1 year. So how can you combine this? Because, you know, really, I like the approach. We have the protocol in our center, of course. You have to talk to the patient. However, many of them cannot do it because, the lack of chemo. So we end up with TUR, deep TUR, radiotherapy, and then TUR again.
Well, I will say that the kind of chemo doses that we're using are very low. These are low dose of platinum and 5-FU or low dose of 5-FU and mitomycin. Almost everyone can tolerate it. We used to do heavy-duty adjuvant chemotherapy beyond. We don't do that anymore because we're uncertain about the benefit and most patients could not tolerate it. A point in which you are absolutely correct is this is very expensive treatment. Chemo, radiation, and TUR, and then a quarter of the patients are going to end up having a salvage cystectomy down the line. It is expensive. But you try telling a woman with breast cancer that you have to have a mastectomy because chemo, radiation, and a lumpectomy is too expensive. I think you'll have a black eye.
Okay.
I think a little bit of the detail here, just for clarification.
Yeah.
Are you using now more 5-FU mito? And if you're doing it, question one, are you doing it and repeating the resection? Because that's not what was in the study.
You know what I'm saying? In the study, the intervals 2/3 of the way through restratification, they ran them through, number one. And number two is, can you add some final clarity for me regarding multifocality and carcinoma in situ as a inclusion or exclusion criteria for trimodality?
We know that multifocality decreases our local control rate, but not by terribly much. So it's not an exclusion criterion. Carcinoma in situ associated with the tumor is no longer an exclusion criterion. And your first question? Yeah, the details. So because we're an RTOG center and we've sort of done a whole series of trials that culminated in 5-FU and cisplatin, we're kind of stuck with that. So that's what we do for our cystectomy candidates. But we're so impressed with the British data that for our older patients, we do mitomycin and 5-FU.
Okay, thank you. Thank you, everybody. Thank you, Anthony. And we have to go to move on for sake of time. And I'm calling Derek Raghavan. Well, Derek is a medical oncologist. He's president of Levine Cancer Center. Everybody knows about him. And he's going to talk us about adjuvant chemotherapy in invasive bladder cancer. Is it state-of-the-art or is it not? Thank you. Thank you again, Derek.
It's a great pleasure to be back in Lisbon. Fernando Jr. and I have been friends for 20, 30, 40 years, and it's wonderful to be here again. I appreciate the opportunity to work with the Portuguese Urological Society. So you've heard some excellent presentations on the state-of-the-art in invasive bladder cancer. And just to remind you, Don Skinner and John Steins and my presentation, as Stephen Riggs said, quite dated now, but strong figures, and these were sequential, not selected cases. The data from Richard Houtman, which show, and the point I'm making here is that while I understand completely and agree that cystectomy is cosmetically and personally an unpleasant operation, with expert surgeons of great talent, you can actually get pretty good results. And the question of whether one does an extended lymphadenectomy or not has been tested in a randomized fashion, and particularly for T2 disease, it does matter. So that's the gold standard that we start from. And then you heard Elizabeth present to you, I think very appropriately, the concerns about neoadjuvant therapy, but reminding you that neoadjuvant treatment is the one dimension of treatment that has been randomized by, that has been validated by randomized trials. And what I think is important is, while she's absolutely correct that the absolute survival benefit from these trials is a survival benefit of actually now 8% with long-term follow-up from the European study, the reality of the situation is this is not curative for the majority of patients. That said, it's important to understand that neoadjuvant chemotherapy does give you a median survival benefit measured in 3 years or more. And that's the SWOG study. I have some proprietary interest in these two trials because I was involved in the design and execution and publication of both of them. And so the median survival benefit and the long-term survival benefit are clear. I agree with Mauricio's comment completely that you do have to select the right treatment for the right patient. And so this is very important. What my topic is to define whether adjuvant treatment is state-of-the-art and is appropriate. And there's been a lot of rhetoric and a lot of bad data that have been presented that unfortunately are being accepted by the community at large. And so I just want to remind you of some of the data that we have. Many of you will have seen this slide from Don Skinner and Richard Cody just shortly before Donald retired, and I had the pleasure of working with him for many years at USC. And this was a study that looked at the prognostic implications of P53 mutation. It's been presented many, many times, and we all know the data that were published in Science by Richard Cody and Donald Skinner. It was an important study. This was tested by the Southwest Oncology Group in a very carefully designed, it was actually the first molecular prognostication study in urology, where we looked at people who had P53 mutation and randomly allocated them after having cystectomy to adjuvant MVAC or observation. And that's the result. There was no benefit from adjuvant treatment. Now let me be clear, this was for P53 mutant disease, and this study did not confirm that P53 mutation mattered in the population of patients that were randomized. But it's an important study because it was carefully controlled and there was no benefit at all from 3 cycles of adjuvant MVAC. This is one of the most damaging slides that has been quoted again and again and again. And it comes from the highly respected Cochrane Group, and it's the one time, to my knowledge, where they actually made a serious mistake. And that is that they did a meta-analysis of studies that actually didn't test the utility of adjuvant chemotherapy. And most importantly, one of the bigger trials was from Michael Stockel. And there's no personal criticism of Michael. Michael did this work in Germany with a cooperative group at a time when the standard practice in Germany was not to use chemotherapy for metastatic bladder cancer. So Michael and his colleagues did a randomized trial after radical cystectomy where they randomly allocated people to adjuvant MVAC, actually MVAC with epirubicin, ×3 versus observation. In that randomized trial, when the observed patients were suffering from a relapse, they were not given salvage chemotherapy. They were sent to palliative care because at that time the Germans did not believe that chemotherapy had any role. So this was not a test of adjuvant chemotherapy versus observation followed by salvage. It was simply a test of the utility of chemotherapy. So it highly prejudiced the interpretation of this meta-analysis, and this meta-analysis was incorrect. And that's an important concept to understand because it's been widely quoted. The Cochrane Group are fabulous, and they do wonderful work But this was a mistake that has never been corrected. Now, the most important study, and it's such a pity that Cora isn't here yet. She will arrive, I think, this afternoon and present tomorrow. But the most important study was done by the EORTC, and it was a randomized trial that attempted to test the hypothesis that adjuvant chemotherapy was of benefit. And you can see the design there. It's very well known. The only thing that wasn't perfect was the fact that there was dealer's choice chemotherapy, GemCis or MVAC or high-dose MVAC, and that was simply a pragmatic decision to try to recruit patients. I have no criticism of the fact that they did it that way, hoping to complete the trial. Unfortunately, at the time, in Europe and in the United States, there were too many urologists and medical oncologists that believed that the question had been answered, and they didn't submit patients to the randomization, and so the study closed early before it had reached its true endpoint. Just to show you the pattern of recruitment, so most of the patients had GemCis, so they weren't really testing the original concept, but if you accept it was a test of platinum-based chemotherapy, it was a reasonable study. At first glance, that looks fabulous, but I remind you that this is progression-free survival. In any tumor type, breast cancer, laryngeal cancer, colon cancer, in any tumor type where chemotherapy works, you have to have a disease-free survival benefit. The question is always, in this group, what happens when you give salvage chemotherapy? And if the salvage chemotherapy brings the overall survival up to equivalent, then you have a null result. Well, in fact, in this study, the salvage chemotherapy did not bring it up to normal, to comparable, but it got to the point where the two survival curves had overlapping confidence intervals. And so the reality is that the only randomized trials that have tested adjuvant chemotherapy have failed to show an overall survival benefit. Now, this is really quite important. The hazard ratio was there, but the p-value was 0.1. I think the biggest concern, and this was discussed at ASCO and it's been presented at the AUA, one of the best discussions I've heard was from Dean Bajoran from Memorial Sloan Kettering. And he looked in detail at the data that the EORTC presented. Now, in the situation of adjuvant treatment for any solid tumor, you would expect that it would be node-positive disease that would have a beneficial impact. You heard Elizabeth and I think Anthony talk about the fact that it was the more advanced disease that has shown benefit from neoadjuvant treatment. Where, in fact, you found the biggest benefit from immediate treatment, the biggest benefit was in patients with locally advanced node-negative disease. And if you look at the pattern of recurrence in the EORTC study, the reality is that the chemotherapy altered the pattern of local recurrence, implying that the heterogeneity of surgery actually harmed that study. And it goes to the point that I think it was Stephen Riggs made. The surgeon who does cystectomies occasionally is essentially a dangerous surgeon. The surgeons who do cystectomies all the time have better outcomes, and that has been shown by her in his retrospective analysis of the SWOG study. It's been shown in Europe and in many other places. And so the reality of the situation is what chemotherapy did in this situation was it overcame bad surgery. Now, that's actually a good thing, but it would be better if the people doing the surgery actually knew what surgery to do. I do want to be very clear. This study was accrued in Europe and in the United States. And we have a big problem in the USA where we have occasional surgeons who do less than 5 cystectomies a year, and they simply do not have the competence to get the same results. I worked for Don Skinner, worked with and for Don Skinner for about 8 years, and in that time, he had 1 local recurrence in his whole series. And I saw all of those cases. So that was the example of an expert surgical team. The other thing that's been mentioned is the so-called real-world studies, the comparisons of very big databases of thousands of patients. And I think the reality is that there's a big problem with big databases. And I view them as Ian Tannock's GIGO principle, garbage in, garbage out. The problem with big sets of data is you don't get any sense of the selection biases that go in. people pick, for example, for chemoradiation, older patients, often with comorbid disease, who wouldn't get a look at a radical cystectomy. On the other hand, the chemoradiation doctors tend to avoid patients with hydronephrosis and with locally extensive disease. So the reality is, when you look at big databases, you simply don't get enough information to really validate whether you're actually finding a true difference. And the big problem is today, which is so dominated by large numbers, somebody who isn't thinking well, who looks at a retrospective set of data with large numbers, will be believed over someone who's actually doing a prospective randomized trial. That's a very bad mistake that we've made recently. So looking to the future, and Elizabeth touched on this in the context of her presentation, the reality is we have some new tools. And you've heard these mentioned. I actually think it is important to be looking at metastases for metastatic disease. Elizabeth is correct. It's very difficult to do. But if it will make a difference between picking the right treatment, then perhaps we need to be disciplining ourselves to do the work. And I think it was Pedro who made the comment that we need to be thinking about circulating tumor cells and looking at circulating DNA. I absolutely agree. We have to build translational studies into the big randomized and non-randomized studies that we have, because we now have technology that will allow us potentially to identify from the primary tumors what is going to be the pattern of cells being thrown off. When they're already established metastatic tumors, we will be able to identify whether we have high expression of PD-1, PD-L1 or not. And so we should be able, with this knowledge, to actually enrich the percentage of patients that will respond. These are very expensive treatments at the moment, and so we clearly do not want to be wasting our resources. There's a very interesting study that I mentioned from the floor a little while ago that Earl Burgess, the medical oncology chief in my group, presented at ASCO GU a few days ago. And this hasn't been done before, and it's tremendously important. What he basically demonstrated, very elegantly, was the difference in expression of PD-1, PD-L1 activity between primary and metastatic tumors in a large number of cases. The reality of the situation is the numbers are vast, the differences are substantial, and they will certainly explain the differential responsiveness to these immunotherapeutic agents. As they are so incredibly expensive for, say, a 6-month course, just using them and hoping for the best makes no sense. While the pharmaceutical companies are paying for trials, it's perfectly reasonable because they provide free drug. But if we are translating this preliminary information into standards of care without this sort of translational information, we make a huge mistake. So I summarize by telling you, and I hope you realize I've picked up 5 minutes in my talk, the Cochrane study was flawed. Real-world studies are subject to case selection biases that are rarely measured. The EORTC showed a non-significant survival benefit that most likely was explained by overcoming mistakes in surgery. And in 2018, patients with invasive cancer who head towards cystectomy, so I'm not getting into a discussion about whether it's good or bad, they should receive neoadjuvant treatment first. I agree completely with Elizabeth. When any of the surgeons I work with tell me that they can get someone successfully through a cystectomy, I can promise them I can get that patient through neoadjuvant chemotherapy. What it does say is that you do need to have a medical oncologist who works regularly in the GU space. The occasional person who uses MVAC is much more dangerous than bladder cancer. You have to have chemotherapists who use MVAC all the time, who understand the implications of the patient who has had a cystectomy and who has some sort of pouch in place. There are so many nuances that make it very important. Thank you for your attention.
Thank you, Derek. I think we have just time for one question. I don't know if there is one question over there. Fernando?
Before you ask this question, Fernando, remember, I knew you when you were a boy.
Well, thank you for your kind words. And the question is very simple. I think it's my opinion, and I think you think when you give neoadjuvant chemotherapy, you always should use cisplatin?
I think that's a very good question. I don't know the answer to that. What I think I would say is that, in my opinion, cisplatin-based chemotherapy, whether it's with gemcitabine or MVAC or whatever, CMV, is the one common regimen that has worked for neoadjuvant chemotherapy. That's a little different from what Anthony was saying, where it's chemoradiation because you have radiosensitization. I think it would be naive to say, yes, you have to. I mean, there are some other good drugs and combinations. I think gemcitabine and Taxol with carboplatin is a pretty good regimen. I've fought over the years with Maha Hussein about whether carboplatin can be swapped for cisplatin, and I don't think it can, except in the context of neoadjuvant treatment with a patient who's not very fit. I don't think the benefit of cisplatin versus carboplatin is necessarily that important. It really hasn't been tested in a randomized trial. I think also the 5-FU platinum approach is a very interesting one. If you go back to the 1980s, there was some very impressive data using non-MVAC regimens. But again, that had platinum. You can use 5-FU and carboplatin. So I think the short answer to your question is I would prefer to use a platinum-based regimen when I can, but if it's not feasible, then I'm happy to look at other things. I will caution you that having an impaired creatinine or a high creatinine is not necessarily a contraindication. And if we go to the case presentations, there's a case I have that illustrates it. If we don't, then I'll talk to you about it over lunch.
Okay, so I think we should move forward. And I just ask you to stay because we are going to start with our clinical cases. So Derek, please go on.
Okay, so I think we can pick up some time here. So this is a patient that we could have been talking about for the last 2 hours. So a 73-year-old man, retired mechanic, so some risk factors, former but not current cigarette smoker, no alcohol, no medications. You can see the presentation: macrohematuria, dysuria, a little bit of weight loss, right flank discomfort. Nothing very important in his past history, family history relevant, but not too exciting. Many families have an occasional case of bladder cancer. Initial investigations I've summarized there, nothing very exciting, with the exception of the fact that, and I hope I've got my SI units correct, 156 creatinine. In the USA, Stephen Riggs, that would be about a creatinine of 1.5. And urinalysis consistent, nothing exciting in the EKG. So basically, a fit elderly patient. Ultrasound, you can see the tumor quite clearly. CT scan, large tumor. I don't have a picture, but there was hydronephrosis present on the right side. No lymph nodes seen, but we all know that a CAT scan for imaging of lymph nodes is not all that helpful, and that's the cystoscopy there. You can see quite clearly high-grade bladder cancer with muscle invasion. So we've got a situation of a clinical stage T2-3 NXM0 urothelial cancer, high-grade, right hydronephrosis, and a creatinine of 156. So I would ask the discussants, what are our options? Cystectomy, neoadjuvant chemotherapy, adjuvant chemotherapy, or chemoradiation? So I think we have some discussants.
I think we have to call our 3 discussants right now. So it's Belmiro Parada, Isabel Fernandes, and Jorge Oliveira. Yes. I would invite you. I would invite you all. Okay.
We'll need microphones for the discussants, please.
Okay. In my opinion, I will neoadjuvant chemotherapy and then cystectomy.
I think chemoradiation
probably with a nephrostomy in the right kidney.
I like that answer. And you think chemoradiation?
No. I was saying that chemoradiation is not an option, in my opinion. I would not go for immediate cystectomy. I would do, as Dr. George said, I would put a nephrostomy, and then I would go for a neoadjuvant chemotherapy, and then probably afterwards for a cystectomy.
Exactly.
Dr. Zeitman, you're a chemoradiation person, and you've said you've treated T2 and T3 disease. This is somebody that you take
This
on?
is a guy we would have routinely treated until about 2009, 2010. But now our data shows that his chance of local control is not so high. I mean, I agree. It's something like 40%, which is not great, substantially higher with the cystectomy. So if he is a cystectomy candidate, we would recommend cystectomy. If he refuses a cystectomy, and some patients do, I will be quite happy to put him in the nephrostomy tube, treat him with chemoradiation, and then reevaluate halfway. If he has a dramatic response, as some do, then we'll continue. If not, we'll have a second attempt at persuading him to have a cystectomy.
So I'm interested just to look at the audience, a show of hands. Anybody would go straight to a cystectomy?
I have a question, sorry. Can you show the microscopic aspect once again? This is the invasive area. I would like to, if it's neuroendocrine differentiation in some area, because looks a little small.
I don't disagree, and we actually, just to tell you the truth, Farhan, we went through serial sections, and our pathologists at the end concluded there wasn't neuroendocrine differentiation because neurocrine markers were completely negative. But I think your point is very well taken. And it's, again, in the same way that I made the point that you have to have an expert GU medical oncologist, as Farhan showed you from nearly the back row, having an expert GU pathologist matters so incredibly much. And so I absolutely agree with that, and we went into it in very great detail. So you're quite right. Okay, so in this audience, nobody would go straight to cystectomy. Perfect. I have to tell you, and I'm embarrassed to say it, in the United States, when I've shown this case, about half the people would have run straight to a radical cystectomy and then planned and would have the argument of they would routinely go to adjuvant chemo. Yes, sir.
I think that perhaps people sometimes say what they expect you to say, because
not in Portugal. They think
in real life, perhaps a lot of people would go directly for cystectomy. My concern about direct cystectomy is that this is a very invasive disease. So perhaps if you go directly to cystectomy, your local control of the disease is quite problematic. So if you do a neoadjuvant chemotherapy, perhaps you improve your chances of local control and better long-term outcome. That's my concern.
Another point is not all the patients accept neoadjuvant.
No question.
So if the patients say yes, okay, but still, 20-30% of patients say no, I don't want it because it's toxic, because I had a family member who had it and it was we are facing also this problem.
Yep.
So saying that neoadjuvant, everybody does a neoadjuvant, it's too much, I think.
So my point was simply who would choose to do it. So the doctors chose that way. I will say, Maurizio, that in our centers, when we have a patient who's reluctant, we will accept that, but we do have them talk to a patient who's been through neoadjuvant chemotherapy and cystectomy. And that's something I learned from Don Skinner 15 years ago, that having a patient who's been through it, who knows the good and the bad, will often help a patient who's frightened from the unknown. So, choice of neoadjuvant regimen, any particularly strong preferences here? Discussants? MVAC, double dose MVAC, gemcitabine cis, dose-dense gemcitabine cis is now the new Memorial Sloan Kettering approach. Any opinions or random personal preference?
I think a cisplatin-based chemotherapy would be an indication, maybe cisplatin gemcitabine or MVAC. If you are thinking that you have neuroendocrine differentiation, maybe cisplatin gemcitabine would be a good option because it works for both of the tumors. And in these cases of differentiation, it's normally a high-grade neuroendocrine tumor. So it works very well, and the surgery works better even for the surgeon because you will have much less tumor in the end.
Yep. And the only argument in favor, I think, of double-dose MVAC, again, it's a pity that Cora isn't here because she did a trial testing this. I think double-dose MVAC doesn't have better cancer killing but the toxicity in terms of myelosuppression is less. The one concern that I've always had is we don't have late follow-up data from double-dose MVAC. And remember that bladder cancer elaborates colony-stimulating factors, so you just don't know what the late toxic effects on the marrow will be. And, it's just an unknown. So I think we've agreed that we aren't going to do cystectomy first, so I think that question is probably not necessary. I can't get the slide to, there we go. So just to let you know what we did, and this was a while ago, we did exactly what you said. We put in a bypass of urinary obstruction, we put a stent in, waited for the creatinine to drop, which it did over 10 days. Our approach at that time was to use standard MVAC. As I said, we might consider double dose for reportedly less toxicity. A lot of people in the United States in community do double dose, but it really hasn't been tested with level 1 evidence. We went to a radical cystectomy, and this is quite important, and it goes to the point that Elizabeth showed. We had pathological stage T0, N0, M0 with the depth of necrosis consistent with T3 disease, and that patient has been clear of recurrence at 3 years, and on our data we would expect that patient to be cured. What would be different for us today, and again Elizabeth touched on it, what is quite clearly important is the whole domain of DNA repair, enzymes, and the genes that correlate. Mutations of DNA repair genes seem to be associated with a very dramatic change in outcome, and I expect, looking at ERCC1, BRCA1, that interaction will govern how we do things in the future. It must be time for lunch. Thank you.
Yes.
We finished the session, and now probably a fantastic lunch. All the people are invited.